Good afternoon, everybody, and welcome to the June 16 APDR National Virtual Noon Conference. My name is Vicki Marks. I'm with the APDR and hosting today, and I'm very happy to bring you today's APDR Noon Conference speakers. Today, our first speaker is Dr. Lori Deitte. She's Professor of Radiology and Vice Chair for Radiology Education at Vanderbilt. And our second speaker is Dr. David Sarkany, Associate Professor of Radiology and the Residency Program Director at Staten Island University, Northwell Health. Welcome, speakers. Here's a couple of housekeeping things. The webinar is being recorded. In addition to questions that are submitted during the conference, those will be posted also. The webinar will be posted on the APDR YouTube channel. It'll take about a week. All the attendee microphones will be muted to ensure optimal quality for the participants. If you have any questions during the conference, please use the Q&A tool. If there's time at the end of the talk, we'll answer the questions. Otherwise, the answers will be sent to you afterwards and sent to the presenters so they can fully answer them. Before we get started, I'd like to thank both Drs. Deitte and Dr. Sarkany for their dedication towards this program and towards resident education in general. We in APDR, and I know that all of you very much appreciate it. Now I'm going to turn over the presentation to Dr. Deitte. I will stop sharing my slides if I can do this right. And it's Dr. Deitte's turn. Welcome.
My name is Lori Deitte, and we're going to be talking about scrotal ultrasound can't miss diagnoses. I don't have any disclosures. And I have two learning objectives. The first one is to describe the key images needed to optimize a scrotal ultrasound. And secondly, to compare and contrast the sonographic features of can't miss scrotal diagnoses. So I want you to just put yourself in this mindset. You are on night float. An emergency department patient presents with scrotal pain. An urgent ultrasound is requested. But the sonographer went home sick. What would you do? You don't have an option to do nothing, okay? So how would you scan this patient? Let's talk about image acquisition. So first of all, positioning the patient. Supine, it does help to just place a towel on the patient's thighs to elevate the scrotum a little bit. What transducer? High frequency, linear, about 14 megahertz. Scan, I like to scan the normal side first, optimize my settings, and then move to the abnormal side. And of course, grayscale, color Doppler, and spectral Doppler are all important. What are some of the key images that we just have to have? And it's important if you're doing the scan to acquire these images, and also if you're reviewing images from the sonographer to make sure that they are there. Side-by-side grayscale testing is very important. We want to compare the echogenicity. And this is a nice example too of the tunica you see here. Side-by-side color Doppler, equally important. Particularly important when the question is torsion and making sure that it looks like there's similar flow in both testicles. Intratesticular spectral Doppler. Make sure this is our gate. We're sampling. Here's the testicle. We want to make sure that the arterial tracing comes from within the testicle. It is not okay to just get it along the tunica and say that that's flow in the testicle. It has to come from within the testicle. And we want to optimize our scale. For instance, in the spectral Doppler, we would like this tracing to fill at least half of the scale. The entire epididymis. I have seen a tendency over the years to be shown pictures of the epididymis that only includes the head, but it's important that we see the entire thing. So here's the head, which tends to be a little bit more echogenic. This is the body, and this is the tail. And then a color Doppler of the same thing, epididymal head, body, tail. These are normal. And then everything else, the scrotal wall, spermatic cord surrounding structures. On this image, we have a testicle, and the scrotal wall has gas in it. This patient had necrotizing fasciitis. So my approach to scrotal pain, first of all, high quality ultrasound is very important because we really do help determine management. Does this patient need to go urgently to the OR or not? So that's my first question. Is urgent surgical management needed? Is this torsion? Is it necrotizing fasciitis? Is there trauma with disruption of the tunica? Versus non-surgical management. Is it epididymitis? And then I have another category, which we'll go over. This is our first patient, a 19-year-old with acute scrotal pain. Our side-by-side grayscale images. I think on these images, the echogenicity looks pretty similar to each other. We go to color Doppler, however, and there's nice flow in the right testicle. There's no flow in the left testicle. No flow. And we also did take power Doppler images. Again, no flow in the left testicle. So this diagnosis of torsion is easy to make when there's absolutely no flow. My question to you is, 4 hours have lapsed between the onset of pain, when the patient first woke up with pain, till they got to the OR. In 4 hours, what is the salvage rate? 80 to 100, 70%, 50%, 20%. It's 80 to 100. And actually, that's a pretty short time. When you think about it, the clock starts ticking when the pain starts. And so the patient wakes up with pain at 2 in the morning. They have to get up, get to the hospital, get to the ER, get checked in, come and see us in ultrasound, and then get to the OR. So important that we help this process move forward. Testicular torsion, then, these are the salvage rates. We just said within 6 hours, it's 80 to 100. Within 6 to 12 hours, 70, and then it really goes down. So our goal as a radiologist is to prioritize these patients, to get their ultrasound done, to do it well, to communicate the results, and to really facilitate their trip to the OR. There's 2 different types, extravaginal and intravaginal. The type that we're talking about today is intravaginal, much more common. These are within the tunica vaginalis. These are the patients that have the bell clapper deformity, more common in adolescent boys. And we're looking for a decreased or absent flow on one side relative to the other. Remember, early on, the grayscale can be normal. And also the epididymis and the testis can enlarge. And that's important because of the other diagnosis that we're frequently trying to distinguish this from is epididymitis. With torsion, the enlarged epididymis will not have flow in it, whereas with epididymitis, it will. And it will have increased flow. And then there's the torsion knot, which we'll look at an example of that in just a minute. One thing clinically is absent cremasteric reflex. It supports the diagnosis. Here's another patient. Again, right-sided pain. There's nice flow in the left testicle, no flow in the right testicle. Right testicular torsion. Another patient, 5-year-old. This is with power Doppler. There's nice flow in the left testicle, no flow in the right testicle. I think this example shows nicely the soft tissue. This is the epididymis, enlarged epididymis around that right testicle that does not have flow in it. This was a very interesting patient. This patient presented to the emergency department with left inguinal pain, and the question was, is there strangulated inguinal hernia? So an inguinal ultrasound was performed, and this is an image from it with power Doppler. There's this bilobed structure in the inguinal canal. One of our radiology, that does not have flow in it, and one of our radiology residents looked at this and said, you know, we really need to do a scrotal ultrasound. Is there any way this could represent an undescended testicle that's torsed? And they were absolutely right. This turned out to be an undescended testicle that had torsed. It was in the inguinal canal. This is another patient that I saw, and this patient had left-sided scrotal pain. This is the right testicle. This is the left testicle. Color Doppler images. Pulse Doppler images. We see arterial flow in the right. We see arterial flow in the left. But I think maybe I can convince you that there's more flow in this right testicle with color Doppler than the left. It has reduced flow. This to me is a huge red flag. I have seen multiple patients with this presentation of torsion. So reduced flow, but not absent flow. Again, the side-by-side images, decreased flow in this left testicle. And what did we do next? We went up to look for the spermatic cord knot, and we found it. So this is where it's actually twisted. And this patient did go to the OR and had left testicular torsion that was salvaged. This is a patient who actually had 3 days of pain before he presented, and so his testicle was infarcted. It's slightly heterogeneous, it's enlarged, I'll show you the comparison, and it has no flow in it. So here is the normal right testicle, this is the abnormal left testicle that was infarcted. Moving on to another category. This is a patient that I remember well, a 26-year-old diabetic, and he was actually, it was early in the morning, and one of our sonographers, I wasn't on ultrasound, but I was walking down the hallway and she came out and got me and said, hey, I really need some help with this. Can you come in and help me? So I went and talked to the patient, and it turns out he's diabetic and he was having some constipation and thought he developed a little perianal fissure. And then the next few days, his scrotum became very tender and swollen. So what is the ultrasound finding? Gas in the scrotal wall. And we can see these echogenic foci with their dirty shadowing. So this is necrotizing fasciitis in this diabetic patient who is quite young. My question to you are the testicles typically involved with this process? Yes or no? The answer is no. And actually, when I talk to my urology colleagues, they've told me that sometimes they actually move the testicles into the medial thighs while they're doing the major debridements that need to occur. So Fournier's gangrene, oftentimes there is some kind of minor trauma preceding it. The testicles are typically spared, and the mortality rate is about 21%. It's mixed microorganisms, and the treatment is broad spectrum antibiotics and extensive surgical debridement. The young patient that I just showed you, even though he actually went straight from our ultrasound suite to the OR, he ended up with 7 major debridement surgeries. Another patient, 30-year-old diabetic. These do tend to much more common in diabetic patients. Here's a normal testicle, extensive scrotal wall gas. This is another image of him, scrotal wall gas, and this is showing ring down artifact. Another patient, 51-year-old, again a diabetic. Again, we see this gas in the scrotal wall. I would caution you on calling this subcutaneous emphysema. That sounds like such a benign thing because we talk about it all the times in patients that have had chest tubes. I prefer to call it soft tissue gas and come right down and say this is necrotizing fasciitis. It's our job as radiologists to communicate the urgency of this finding. This is what this patient's CT looked like. He had extensive involvement. Moving on to another category. So this patient, rowdy fraternity party, and a couple hours later, he woke up and had a discolored, enlarged scrotum, painful scrotum. So what are our ultrasound findings? Well, we're looking at a testicle that has flow in it, but there's some other findings. If we follow the tunica, we see that it stops abruptly right here where it's disrupted. Here's the tunica, stops abruptly. And through this huge defect through the tunica are extruded seminiferous tubules, which do not have any vascular flow in them. So this is testicular rupture. The role of ultrasound is very important in this. And the patient that I just showed you, that was a major, major disruption. The tunica disruption was very easy to see. Sometimes it's much harder though, and so there's other signs, secondary signs. Contour irregularity of the testicle, altered testicular echogenicity due to hemorrhage or infarction with maybe an adjacent hematocele, decreased Doppler flow. Why is this important? Because we want to salvage the testicle if at all possible, and a 90% salvage rate within 72 hours, but then it goes down quite a bit afterwards. This is another patient that we had. A gunshot, unfortunately, to the scrotal region. We can see some air in this right testicle. We can see there's flow. And as we follow this tunica, we just kind of lose it in this lower pole. And we can see that the testicle margin becomes very irregular. And there's actually some blood next to the testicle. So we call this testicular rupture of the lower pole of the right testicle. Preoperatively, and in the OR, this was a disrupted tunica with testicular rupture that they were able to repair. And this was a patient that I saw on call, fireworks mishap to the scrotum, and we can see extensive gas in the soft tissues. It primarily involved the left part of the scrotum. A huge hematocele surrounding this very, very irregular left testicle that was completely disrupted. This patient, a 53-year-old with left scrotal pain and swelling, and this was sort of interesting in that the sonographer brought me images of both testicles and epididymi that looked completely normal. And so I asked her, what does the patient look like? And she said, oh, he's got really a lot of swelling. It's very, very painful. And to me, this is a huge red flag. My images are not matching the clinical presentation. So I went in to scan the patient. I will say that I really do prefer to go in and scan these patients whenever possible for scrotal ultrasound. So this was our left testicle that looked fine. But the first thing I did is I asked the patient where he hurt, and I placed the transducer there. And it turns out his pain was actually in the perineum along the undersurface of the left testicle. And the first thing I saw when I looked was this huge abscess. It was 10 centimeters. That would have been missed had I not gone in and scanned, at least from our imaging standpoint. So I was really grateful that I went in to scan, and this patient went to the OR and had this drained. And this is another patient, a 52-year-old, who had a huge scrotal abscess on this ultrasound image. And then the CT image, huge abscess. Okay, moving on to another category. So we talked a little bit about the epididymis and how we image it. Showing you an image of a patient who was having pain, and this is his right epididymis and his left epididymis. So which side hurts? Can I convince you that the left epididymis looks more vascular, it's hypervascular, and this was early left epididymitis. But you can see the value to imaging the entire epididymis because the epididymal head really doesn't look very, hypervascular on here. And if we almost only would have imaged the head, we probably would have missed this. Epididymitis, really common. You'll see a lot of patients with this during practice. It is actually the most common cause of postpubertal acute pain. I've listed the organisms here that can cause it. The main thing that I want you to take home from this is that it can be focal or it can be diffuse. And if it's focal, it starts in the epididymal tail. So we have to image the entire epididymis or we're going to miss some of the diagnoses. It can extend to the testes, in which case it's called epididymo-orchitis. That happens about 20% of the time. Also, patients can have focal orchitis, which will look hypoechoic but have increased vascularity. It can, on occasion, progress to venous occlusion and infarction. I have seen this kind of rarely, given the number of cases that I've seen. So here's our patient. They were having scrotal pain, and we're looking at the right testicle, the right epididymis. We do see a small hydrocele here on the right, and then the left testicle, the left epididymis. So have we excluded epididymitis? Do we think that's what's going on here? What else do we need to do? We need to see the entire epididymis. And when we scan down to the right epididymal tail, we can see this is very enlarged, heterogeneous, hypervascular. This is a patient that had right epididymitis that was predominantly involving the tail. Very important to scan the entire epididymis. And this is a patient who had 3 days of pain before he came in. These are our side-by-side color Doppler images of the testicles, right, left, clearly very hypervascular right testicle. And we can see extremely vascular right testicle, right epididymis. This is very severe right-sided epididymo-orchitis. This is a 6-year-old with right scrotal pain. So we're looking at the testicle, which has flow in it. And I would tell you this came across as rural torsion. There's another finding. And I'd like you just to look at the image and see what you think. Okay, and the finding is this hyperechoic soft tissue that is extratesticular, abuts the testicle, has no flow in it, but has a little bit of vascularity around it. This is a torsed appendix testes. Okay, so this is torsed. And that pain due to torsion, it can be very severe. Usually, if we do see the little appendix testes, it's usually really small, like just a couple millimeters. But when it becomes torsed, it enlarges. So torsion of the appendix testes is predominantly a pediatric diagnosis, 7 to 14 years old. Presentation can mimic testicular torsion as far as the degree of pain. We see an avascular hyperechoic mass, which is the torsed appendix, and we can see a surrounding hypervascularity. In contrast to testicular torsion, the cremasteric reflex is still typically elicited, and you may have heard about the blue dot sign, which is what can be seen due to the torsed appendix. The important thing to remember is that the management is conservative. So this is an important diagnosis for us to make. This is a patient who gave a history of minor trauma, just kind of falling in the bathtub, and his left scrotum was enlarged. So he came to the emergency department and came to us with rule out testicular rupture. These were his images. The grayscale images, the right testicle is normal, the left testicle is enlarged, heterogeneous. And if we only looked at this, we might be thinking, oh, is there a bunch of hematoma in there? What's going on? We turn on color Doppler, and we see that this is in fact hypervascular. And hematoma does not have flow in it, so this is hypervascular. If we didn't have that history of trauma, the really first thought we would, in this patient, the epididymis, there was no epididymitis, and we could see some normal parenchyma, would be tumor. And that's what this was. This was a seminoma. I will say over the years, I have seen multiple patients, actually, it's not the typical presentation for tumor, usually it's a palpable lesion, but I have seen multiple patients present with their germ cell tumor with come in for like rule out torsion or rule out trauma. This is a 31-year-old patient who presented with scrotal pain, and I'm showing you the right testicle and the left testicle. There was a single hypoechoic lesion in each testicle. With color Doppler, there was less flow in the hypoechoic lesion than the surrounding stroma. So this was actually done in the middle of the night, and the first communication was this could be bilateral germ cell tumors. Urology was consulted, and I came in the morning and overread this, and there was more history available at the time that I saw it. The patient had been experiencing an upper respiratory tract infection, and they thought he had pruritus nodosa. And so on discussion, consultation with the urologist, we decided maybe the most prudent thing would be to perform just a short interval follow-up. So this is the initial left testicle lesion, and this is just 2 days later. We can see there's multiple lesions. These turned out to be infarctions. We followed them for quite a while, but they turned out to be infarctions. And this patient I remember as well. He's 61 years old, and he had actually had a normal ultrasound just the year prior. He came in with this very painful new left varicocele. So my question to you is, what would you do next? What are you thinking about with this new varicocele? What could this be? So our thought was, this is abnormal. A 61-year-old to get a new varicocele. First thing you think about is, could this be a secondary varicocele? Does he have a retroperitoneal mass? Does he have a renal cell carcinoma? So we want to image the kidneys. And in fact, his presentation, this was his presentation for his renal cell carcinoma, was this new onset of a painful varicocele. And he had a large renal cell carcinoma that was involving his renal vein. A patient that came through the emergency department with scrotal pain and had this ultrasound. This is a normal testicle, and this is a large soft tissue mass superior to the testicle and going into the inguinal canal. It was fairly homogeneous. It did not have a lot of flow in it. When I talked to him, I went in and scanned, and when I talked to him, he said he had actually had like some swelling that had been growing for about a year there. And now it just got to the point where he couldn't really stand it anymore. And so we know that most extratesticular masses are actually benign, but there are some that are malignant. And one of them is a liposarcoma of the cord. So that was actually the thought process that I had. Well, this could be a liposarcoma. This definitely needs to, it's been growing over a year. It needs to be further evaluated. And the patient did undergo a CT. And this was resected, and this was a liposarcoma. It was a well-differentiated one with some ixomatous changes. But just remember, liposarcomas can occur in the cord. In contrast, this is a patient who had been lifting 50 pounds, I think, or something, and developed acute pain. And he came in, this is the images of his testicle, I think the right testicle, and then he had this soft tissue mass above his right testicle that we could follow all the way through the inguinal canal. And this is what fat tends to look like when it herniates. And he had an incarcerated hernia. It could not be reduced. He was really having excruciating pain and ended up going to the OR to have this repaired. He did not have bowel herniated with it, but that's the other thing that you would look for. And this is how big it was. There was actually a lipoma in his cord and also the hernia, but here's his testicle. It was impressive. Okay, so I'd like to wrap up the session, our whirlwind tour of can't miss diagnoses, by let's once again go over our key images. So side by side, grayscale images of the testicles, absolutely have to have. I would say I've already seen diffuse leukemic infiltration of one testicle that was most apparent on those side by side images because it involved the entire testicle, which was hypoechoic. Side by side color Doppler images. Key images. Remember, especially for torsion, we saw some patients that had complete absence of flow in a torus testicle, but we also saw a patient that had reduced flow, but not completely absent, and it was testicular torsion. Obtain your arterial tracing from within the testicle and optimize your settings. Remember to look at the entire epididymis, the head, body, and tail. We know that focal epididymitis can occur and it tends to occur in the tail. And then color Doppler images. And then everything else, all the other soft tissues in the area. Our patient who has a normal testicle but necrotizing fasciitis. Our can't miss diagnoses, testicular torsion. I'm going to start with the ones that are urgent, have to go to the OR urgently. So testicular torsion, torus left testicle here. We make a big difference here. We've got to get this done quickly and communicate urgently. Necrotizing fasciitis really is, it progresses very quickly. Again, very urgent to get the urologist involved. Trauma, and here's our tunica that's completely disrupted. Again, we're looking for tunica disruption. We're looking for testicular irregularity. These patients then would go to the OR. Incarcerated hernia is also urgent. And this was our patient who had an incarceration, fat-containing hernia. Abscess. We looked at patients with abscesses. Medical management, epididymo-orchitis. Remember our patient. And remember, though, it can be focal. And then our tumor category, we had a patient, looked at a patient with a secondary varicocele as his presentation for his RCC. We reviewed a patient that had his testicular neoplasm present as he came through the emergency department with pain. And we also, our liposarcoma patient of the cord came through the emergency department. I'd like to thank you very much for your attention. I'm going to go ahead and stop.
Thank you, Dr. Deitte, for the wonderful presentation. I know all the attendees appreciate it, and if we were all sitting in a room together, there'd be a big round of applause. I'd like to ask Dr. Sarkany now to share his screen and to begin his talk. Thank you.
Thank you very much to Dr. Betty and Dr. Marks for setting this up with the APDR. And thank you, Dr. Deitte, for a great lecture on scrotal ultrasound. Today, I'm going to be talking about TI-RADS, which is the thyroid reporting system. And this is really what should be your Bible for every time you read a thyroid scan. So in 2017, ACR came up with this grading system, which has been extremely helpful. Thyroid nodules have always been very difficult for most radiologists to give accurate information on, yet it's one of the easiest modalities for the referring physicians to ask us to review thyroid lesions. Just a quick review of this diagram is at the top of the diagram, we have 5 areas that we're going to look at each nodule: composition, echogenicity, shape, margin, and echogenic foci. Each nodule will get a point and possibly 0 points for each one of these. Then you'll add it together, and then you'll put it into one of these categories, and then you'll decide from there if an FNA is needed or if we're going to follow up in 1 year, depending on the category. So this is patterned after BI-RADS from breast imaging. And as many of you know, there's LI-RADS and even lung-RADS. So there's this idea going towards this grading system because it's very helpful for the referring physicians. So just a quick background. So thyroid nodules are increasing in numbers in a certain sense. And the reason why is because we're doing so much more imaging that it's actually just more of an incidental finding. So it's not that people are getting more thyroid nodules than they were 100 years ago. It's just we're catching them more often because we're doing more imaging. So the nodules are extremely common, but the incidence of malignancy is extremely low. And even the ones that are malignant tend to be papillary type, which tend to be indolent and slow growing, and many times would not be the cause of someone's death, meaning that someone could live with thyroid cancer and we wouldn't necessarily have to do any kind of treatment, which definitely throws a curveball into our diagnostic needs. And there's definitely an argument for small cancers not to do thyroidectomy, but just to watch. Before we begin, and we're not going to really go over the anatomy, but you should be somewhat familiar with the anatomy of the thyroid gland and the adjacent structures. So just a quick picture. One thing I really want to point out to you is this is number 1 is your thyroid gland. And in comparison to your strap muscles, it is more echogenic than your strap muscles. So the strap muscles are hypoechoic, and that's going to be helpful for us later on when we start categorizing nodules. So my objectives for this talk is definitely the first 2, to review the lexicon of TI-RADS and correlate it with images. And if we have time, we'll try to go over some examples. So the whole reason why radiologists came up with TI-RADS is there's been so many different ways of analyzing thyroid nodules from different organizations that's been very hard for there to be any sense of consistency. Number 1 for radiologists, but number 2 for the referring physicians to know what to do with our descriptions. And many times in the past 10, 15 years ago, the endocrinologist wouldn't even know what to do when we spoke about a nodule. So this is really helpful for us. Number 1, it stratifies the risk of malignancy. Number 2, it does standardize terminology. So if I give a thyroid report in New York, somebody in California will be able to understand where I'm coming from. And one of the most important things is to provide some clinical management. Are we going to biopsy or are we going to watch? This is really important because, as we said a couple slides ago, a lot of these cancers are indolent and may not need any treatment. Produces a lot of healthcare financial strain as well as anxiety on the patient. So if we can do a better job, it would be helpful. And TI-RADS has definitely added towards our ability to improve our diagnosis. There's going to be 5 categories, which I showed you on that diagram: composition, echogenicity, shape, margins, and echogenic foci. These categories were decided using evidence-based medicine that allowed us in the literature to distinguish between benign and malignant nodules. And if you look at this and you compare old articles, we're not talking about size here, and we're not talking about vascularity, which are 2 things that used to be mentioned, as well as other things that used to be mentioned, because those haven't been shown to definitively tell you, although none of this is definitive, but it doesn't lead you definitely from benign to malignant, although size is going to have an important component to our recommendations. So first is composition. There's going to be 4 different areas that we're going to look at, 4 different kinds of composition. Cystic, meaning that's going to be less than 50% solid. Spongiform, which is exactly what the term is. It's going to look like a sponge. So it's going to be a solid nodule with a bunch of tiny cystic spaces. Mixed, which is about 50% solid and 50% cystic. And solid, which is going to be greater than 50% solid. And each one of these will get a specific point. So this is an example of cystic or almost completely cystic. Less than 50% of this is solid, or greater than 50% is cystic. And cystic lesions tend to be shown not to be so malignant, so this gets 0 points. A couple points that are important with respect to the solid component is sometimes it's difficult to know if it's solid or if it's blood products or debris, and utilizing Doppler to see if there's any flow in it will help us decide what it actually is. And something else that's really important is, are there acute angles of the nodule within the nodularity within the cyst? So if you look over here, this is an obtuse angle of this portion of the solid component. If it were an acute angle, and even if this was a mostly cystic lesion, acute angles with nodularity with blood flow in it is definitely more suspicious than obtuse angles. So it's something that you want to definitely look out for. This is an example of spongiform. So it's a solid lesion with multiple cystic spaces. So you don't just want 1 or 2 cystic spaces. You want it to be scattered throughout the lesion. And again, this is 0 points. This is not a great example, but an example of a mixed cystic and solid, about 50%. Again, we're just looking at this visually. You don't have to actually measure. And this would be given a 1 point. This is a solid lesion and would be given 2 points. And then this next one is probably what you're going to see more commonly, is a mixed cystic and solid, but more than 50% of the lesion is solid, and therefore it's also going to be given 2 points. So if it's completely solid, 2 points. If it's greater than 50%, it'll be 2 points. So the important thing here is to get a understanding of the whole nodule and visually decide how much is solid and how much is cystic. The next category that we're going to look at is echogenicity. So the level of the echogenicity is of the solid, non-calcified portion of the nodule. So clearly, if we're talking about a pure cyst, then we're just going to have fluid and it's going to be anechoic. And if you look at the the diagram that I initially showed, that would give you 0 points. So this is an example of that. But then once you start talking about having some solid components mixed with a cystic component, you're going to look at only the solid component to decide the echogenicity. And for hyperechoic, isoechoic, and hypoechoic, you're going to compare it to the normal adjacent thyroid tissue. For the category of very hypoechoic, you're going to compare it to the neck musculature. And if you remember from one of the first slides, the neck musculature tends to be extremely hypoechoic. So that's what you're going to be comparing to. So this is a echogenic or hyperechoic nodule as compared to the adjacent thyroid tissue. For both hyperechoic and isoechoic, so this image is just of a hyperechoic one, but for isoechoic lesions, you're going to be giving it a 1 point. Isoechoic is going to look like the same echogenicity as the adjacent thyroid tissue. This is an example of hypoechoic as compared to the adjacent thyroid parenchyma. This would be given 2 points. And this is an example of very hypoechoic. So if you look up here at the blue arrow, this is one of your strap muscles, which is a very hypoechoic structure. This nodule within your thyroid, this is a transverse image. So the thyroid tissue, sorry about that, is involving this whole area, is extremely hypoechoic. It's almost as hypoechoic as the carotid artery. So this is given 3 points. The next thing that we will look at is the shape of the nodule. And there's 2 categories here, taller than wide or wider than tall. Taller than wide is suspicious for malignancy based on the literature. They think it may be related to decreased compressibility of the nodule. And if you notice this with your nodule, then it's going to be given 3 points, as opposed to the other is wider than tall will be 0 points, because that's more consistent with the benign nodule. We will look at this comparison of taller than wide on the axial or transverse images. We do that more out of consistency. We could have theoretically picked in sagittal dimension, but we're across the board using transverse dimension. And you want the ratio of sizes to be greater than 1. So this is your typical dimensions of a nodule. You're going to have a sagittal view and a transverse or axial view. Again, the wider than tall or taller than wide will be viewed on this image. And this over here is actually an example of wider than tall. So this distance, this wide distance, is greater than this distance over here. So this would be given 0 points. While this lesion, again, another axial or transverse image, we have our trachea over here. This is your isthmus, one of your strap muscles. This whole area here, I know it's only one image, this whole area here is your thyroid nodule. And clearly it's definitely taller than wide and would be given 3 points. The next category is the margin of the nodule. So with respect to the diagram, they clump smooth and ill-defined together as one thing, irregular and lobulated together as another, and extrathyroidal extension as a third one. Smooth margins are, as it sounds like, it's a well-defined, curvilinear, usually round or oval nodule, no interruptions. An ill-defined nodule is going to have at least some component of the thyroid nodule where you'll have trouble distinguishing it from the adjacent thyroid tissue. Irregular is defined as a spiculated or jagged portion of the thyroid nodule with sharp angles. Again, it could be present in only one small portion. So most of the nodule could be smooth except for one small area. Lobulated is very similar to when you see a lobulated liver contour in cirrhosis. You can have large lobulations or small ones. And extrathyroidal extension is pretty extensive disease at that point. So this is an example of a smooth margin. It's pretty well defined all around. And this would be given a category of 0. Again, if it's ill-defined, then you'll give it a category of 0 as well. Not a great image, but we're definitely losing a portion of the thyroid gland, and it's hard to make a discrete border with respect to it. So a portion of this nodule is ill-defined. So this is a nice example of an irregular margin. You can see it's, there's sharp angles, it's jagged, it's irregular. This would be given 2 points, and the lobulated one will also be given 2 points. So here we have some nice lobulations, again, very similar to what you would see when you're looking at a cirrhotic liver. And then finally, extrathyroidal extension, where essentially you're losing the fat plane between the thyroid gland and the strap muscles, and it's turning into one big mush. So this is obviously extensive disease. And the last category that we're going to look at are echogenic foci. So these are going to be small areas that are very white, increase echogenicity on your scan. We're going to divide it into 4 areas. It's going to be comet tail artifacts, which is really a reverberation artifact. They're essentially look like white triangles that will be within your nodule. Macro calcifications, as opposed to micro. Macro calcifications, you'll see some acoustic shadowing, just like you would see with the gallstone. Peripheral calcifications will involve the periphery of the nodule. It doesn't have to involve the whole periphery of the nodule. Most of the time it does involve most of it, but it doesn't have to. And many times it might be dense enough to cause acoustic shadowing so that you can't see the rest of the nodule. Just in reference to those nodules, we're going to assume for grading purposes that they're going to be solid in composition and ill-defined with respect to the margins. And finally, punctate echogenic foci are going to be very tiny dots, microcalcifications, no shadowing, and they're not always truly microcalcifications, but sometimes they could be related to tiny cysts and some artifact from the back wall of the tiny cysts. So this is a nice example of comet tail artifact. If you have no calcifications, or if you have these comet tail calcifications, we give it 0 points. This you typically will see in benign colloid nodules. This is a nice large macrocalcification with posterior acoustic shadowing. This would be given 1 point. An example of peripheral calcification. So if this calcification were covering the anterior portion, you would get shadowing very similar to this, have a hard time describing this nodule, and the literature says we'll assume it's smooth, we're going to assume it's solid, and you're going to assume it's hypoechoic, if I remember correctly. And finally, punctate echogenic foci are going to be tiny white little dots, could be scattered throughout the nodule, could be in a very small portion of the nodule, and this is going to be given 3 points. So just as a quick review of the TI-RADS, and then we'll try to get into some examples. We have 5 lexicon categories. We go from benign, not suspicious, mildly suspicious, moderately, and highly suspicious. The scoring is based on a point system. So you're going to be given a point of each one of those 5 categories to give a total sum. And that sum will tell us which risk category is going to be in TR1, TR2, TR3, 4, or 5. Each one of those will have specific recommendations. We're not using size or elastography. Mostly elastography, although there is some benefits to it. Many places don't have it as a component. And since we want this TI-RADS system to be taken up by everybody, elastography was not included. Size was not included because just because you have a big nodule does not mean there's an increased risk of malignancy, and you can have a sub-centimeter nodule that's malignant. It does help guide us, but it's not a definitive component to the TI-RADS. So recommendations for FNA and nodule follow-up will be given by the TI-RADS level, which is adding up the points, and the maximum diameter of the nodule. Biopsies and follow-up are for TR3, 4, and 5. TR1 and 2 require no follow-up. Just as a quick aside with respect to size, it's not an independent predictor of malignancy, as I said. So even nodules that are greater than 2 centimeters are statistically significant, show increased risk of cancer. We're not sure if that's clinically relevant. So going way back to the beginning, a lot of these thyroid cancers are indolent, and although they may be cancerous, may not have clinical significance. So they're used for us to decide whether to follow or FNA, but they don't help grade the nodule. So the interval for following up thyroid nodules for a TR3, if it's less than a certain size based on the diagram, you're going to have a follow-up at 1 year, 3 years, and 5 years. For TR4, 1 year, 2 year, 3 year, and 5 years. And for a TR5, you're going to do it every year for 5 years, depending on the specific size of the nodule. Now, what happens if you have 2 nodules? What happens if you have a bunch of nodules that you feel like you have to biopsy? So the criteria that has been established is to not biopsy more than 2 nodules and the other nodules to follow. And more often than not, the nodules that need to be followed will potentially be a borderline nodule follow-up versus biopsy. And following it up in a year is not going to cause any clinical significant risk to the patient. So let's do some RAD path correlation. So this is an example of a nodule. It measures up to 3.2 centimeters in greatest dimension. This was a transverse view. So if we, again, look at our 5 categories, it's a solid nodule, so it gets 2 points. It's hyperechoic as compared to the adjacent thyroid parenchyma. Again, we're looking at most of the solid components to make that decision. It's wider than tall, which is 0. It's a smooth border, well delineated. That's a 0, and there's no echogenic foci. So if we add this together, 2 + 1 is 3. This gives us a TI-RADS 3, which is considered mildly suspicious. The rule is if it's greater than or equal to 2.5 centimeters, then we'll do a fine needle aspiration, which is a definitive way to diagnose if something is benign or malignant. And if it's greater than or equal to 1.5, then we're going to follow. And remember what we said a couple slides ago, we followed in 1 year, then 3 years, and 5 years. Now, it happens to be in this case, this one was actually aspirated, and the cytopathology was benign. Just to reiterate, so if this nodule was less than a centimeter with a TI-RADS 3 score, according to the rules, we don't need to follow it. We only need to follow it if it's greater than or equal to 1.5 centimeters. Here's another TI-RADS 3. This one's 2 centimeters. The measurements I'm giving you is just so you get an idea of what the nodule actually is. So most of this nodule, this is a very good example of how do you decide, is it more solid or cystic? So visually, this is clearly more solid. So it's gonna fall into the solid composition. You get 2 points. We're gonna just look at the soft tissue component compared to the adjacent thyroid tissue. We see that it's isoechoic, so it gets 1 point. And it does have one large common tail artifact, and this one is going to give you 0 points also, similar to no calcifications. We got 2 plus 1 is 3. That gives us a TI-RADS 3. Because it's a 2 centimeter nodule, we're going to follow it by TI-RADS guidelines in 1 year. This one happened to be FNA'd and ended up being a benign colloid nodule. But the correct way of doing this, if you see this in practice, is to recommend a 1 year follow-up. Here's another one. So we got both transverse and sagittal views of this nodule. Clearly solid. It's hypoechoic, but not decreased in exogenicity as compared to the strap muscles. It's hypoechoic compared to the relative thyroid tissue, adjacent thyroid tissue. It has an irregular border. So you might ask me, where is this irregular border? Where's my arrow? Right in this area here, you kind of lose a normal border. It's jagged, it's sharp. So most of the nodule is well delineated except for that portion, but that's all I need. That gives me 2 points for a total of 6 points. A TI-RADS 4 is 4 to 6 points. We're gonna FNA it if it's greater than 1.5. And as I said, this was a 1.8 centimeter nodule. And the diagnosis was papillary carcinoma. If it was a 1.2 centimeter nodule, then we would follow. Okay, this one is a 7 centimeter nodule, clearly solid. It's taller than wide. I don't have the measurements here. This is a sagittal image. This is your axial image. And this will give me a total of 6 points. And again, with the 7 centimeter, we're gonna FNA it, but this was found to be a benign multinodular thyroid nodule. And I think this is our last one. Again, a very big nodule, 7 centimeters, clearly solid. Yes, it does have a cystic component, but greater than 50% is solid. It's lobulated in appearance. You can see the lobulations right here. It has punctate exogenic foci in a small little area of the thyroid nodule. It gives us a total of 8 points. 7 or more points is a TI-RADS 5. Because it's greater than 1 centimeter, we're gonna fine needle aspirate it, and this ended up being follicular carcinoma. So again, oh, one more, is we got a 4 centimeter nodule. This one is solid, has a lot of echogenic foci, ends up being a TI-RADS 5. This one was FNA'd and actually was a benign lesion. So use that diagram that I showed in the beginning, and that will help you on all your thyroid reads. And thank you very much. And thank you very much for the APDR. If you have any questions, you can email me or call me on my cell. Thank you.
Thank you, Dr. Sarkany. I want to thank both speakers, Lori Deitte and David Sarkany, for your presentations today. As we mentioned, the presentations will be available within about a week on the APDR YouTube channel. Also, the questions that were submitted will be answered by the speakers. I want to thank all of our participants today for joining us, and we look forward to having you again on Thursday. And please, everybody, stay healthy. Have a good afternoon. Bye-bye.